My name is Michael Pulsipher, and I am currently located at Children's Hospital Los Angeles. And today I'm going to be addressing a very important topic about factors that contribute to stem cell consolidation after CAR T cell therapy. Now, I want to state outright that the way I approach this is my goal eventually will be to never do another bone marrow transplant, but we're far from that, unfortunately. There have been in the last several years a number of CAR T cell products that can offer curative therapy that now are out. I have my own patients who are out greater than 5 years. The original patient treated with this therapy now is out greater than 9 years. So that's important to keep in mind. This can be a curative therapy. So the first factor that's incredibly important for all of us to understand is you have to know your CAR T cell construct. Has it been demonstrated in the way it's manufactured and the way it's put together to last long term? Because we know that patients treated with ALL need to have at least 9 to 12 months and preferably longer of presence of CAR T cells in order to really have a very high chance of cure. If you have a CD28-based CAR T cell construct, it's highly unlikely that it'll last more than 6 to 12 weeks. On the other hand, many of the 4-1BB-based constructs that are manufactured in the correct way can last years, and that's what you need. So that's the key factor. If you know that your construct isn't going to last very long, it's an easy answer. Get your patient into a deep remission and then move on. Now, many other factors have been considered. Very recently, I published data and others have published data that has shown that there are certain risk factors for increased likelihood of failure. One risk factor is a very high disease burden at the time of CAR T cell therapy. Now, that's been defined in various ways. One group defined it as greater than 1%. One group defined it as greater than 5%. One group defined it as greater than 40 to 45% after lymphodepleting chemotherapy was given. So we don't have exactly the most precise definitions, but bottom line is patients who have high levels of NGS, high levels of disease present at the time of CAR can relapse in higher rates. Now, they'll go into remission, almost all of them. In fact, high disease burden, more than 80% of the time, with a very good CAR construct, will go into remission, but it just has a much higher chance of relapsing later on. A second thing that we, again, recently identified in a publication is the failure to respond to a previous course of blinatumomab. Now, originally we thought it was any blinatumomab use, but on very careful sub-analysis, we published in JCO that those who fail with blinatumomab are the ones that are more likely to fail later on. Now, I want to finish this by stating the most important factor based on a number of studies that I just completed and published in the journal Blood Cancer Discovery a very detailed analysis of many factors associated with failure of CAR T cells, which would lead you to potentially move toward allogeneic transplant for consolidation early before that failure occurs. We looked at cytogenetics, didn't find anything that was really telling. Some cytogenetic abnormalities seemed to be a little bit worse, didn't have a lot of numbers. The a couple of Chinese investigators have reported that P53 abnormalities may be the one thing to go to, but we didn't see that in our data. We looked at a wide variety of other factors, but the only things that really mattered were B-cell aplasia, continued B-cell aplasia, which shows the presence of the CAR T cells, and NGS-MRD as detected by the adaptive clonoSEQ assay. Now, the key with NGS-MRD is the level of cutoff. We found that this is a highly sensitive and highly specific technique. And so any detectable, whether it's at 1 in 10 million, any detectable disease mattered. Therefore, what we found was by the time you got to 3 months after transplant, if patients had any detectable NGS MRD, then they were almost 100% destined to relapse. Early on, at day 28, there was a small percentage that had one positive result and then later on became negative and were long-term responders. So it may be wise to repeat this assay at least once, but bottom line is any detectable NGS MRD that shows up within 1 to 3 months after CAR T cells means that there's a high chance of relapse. Also, loss of B-cell aplasia. If you lose B-cell aplasia early, in the first 3 to 6 months, it is highly likely that you're going to relapse. Losing B-cell aplasia at 9 months, 12 months, you may be a little bit worse off, but once you have the presence of CARs for at least 9 to 12 months, your likelihood of long-term response to CAR T cells really matters. Now, a final thing to say is there is a debate right now whether you should just take anyone who's not already had an allogeneic transplant to transplant after they've had CAR T cells. In other words, consolidate all of them. We really don't have the data to say that for sure if you did a randomized trial between taking patients, 100% of them, to allotransplant if it's their first procedure after CARs, versus patients who could be screened by NGS MRD or loss of B-cell aplasia, which would lead to a better outcome. We actually are planning a study called the CAR Cure trial, where we're going to test the feasibility of being able to move patients to transplant rapidly should they fall into the high-risk category based on NGS MRD and loss of B-cell aplasia. And that study should be starting in the next couple of months. After a pilot trial, we hope to do a randomized trial. So we should have definitive data soon. But in the meantime, we can say with a great confidence that, again, patients who have presence of NGS MRD 1 to 3 months after transplant, after CAR T cells, or even later after CAR T cells, highly likely to relapse. Consider moving to transplant quickly. If you get them to transplant while they're only NGS MRD positive and they're not flow positive, they have a very decent chance of curative therapy. Also, follow patients who have high disease burden or patients who have failed blinatumomab prior to going to CAR T cells very closely because those patients are likely to fail. And patients who lose B-cell aplasia within the first 6 months, those patients are also highly likely to fail, and it would be very wise to consider moving them to transplant if they're in a good remission.